With your hosts, Lily Mundy, Raj Parikh, and Kyle Sanniec, this is the award-winning PRS Journal Club podcast.
Hi, everyone, and welcome to the August 2019 edition of the PRS Journal Club podcast. I am Kyle Sanniec, PRS Resident Ambassador from UT Southwestern, and I am joined by my co-resident ambassadors, Lily Mundy from Duke University and Raj Parikh from Washington University in St. Louis. Today we have the honor of being joined by Dr. Justin Sachss. Dr. Sachss is an associate professor of plastic and reconstructive surgery at Johns Hopkins University, where he is also the director of oncological reconstruction. Thank you so much for joining us today, Dr. Sachss.
Oh, it's my pleasure. Thanks for inviting me to this.
The articles that we will discuss can be read for free on prsjournal.com, including an archive of all past Journal Club articles. The article we will be discussing today is Survival Following Self-Inflicted Gunshots to the Face by Dr. Arthur Nam at a Shock Trauma Center. Hi, everyone. Welcome to the PRS Journal Club podcast. The article we will be discussing today is Survival Following Self-Inflicted Gunshots to the Face by Dr. Arthur Nam at a Shock Trauma Center. The purpose of this study was to review their series of patients with gunshot wounds to the face to provide prognostic and management guidance for treating this injury. And they did this by doing a retrospective review of all patients aged 18 and older from 2007 to 2016 who had isolated self-inflicted firearm injuries to the face. They defined this as the chin to the hairline and laterally to the external meatus were included. They looked at in-hospital mortality and other demographic variables, including injury patterns and hospital course. A total of 69 patients met the study criteria, and 90% of those were male. They found that 38% of patients transported to their facility died from these injuries prior to arrival. The most frequent injury patterns were submental, followed by intraoral. Less than half of the patients sustained penetrative brain injury. The total mortality rate was 26%, of which 95% of those patients were caused by penetrating brain injury. This was an independent risk factor for mortality as well as age, with a mortality rate of 17% among patients less than 65 years of age and 73% for patients older than 65. They conclude that despite the morbidity, a majority of patients who present with gunshot wounds to the face will survive, especially if they have no penetrative brain injury. They argue that this information can be used to guide decision making. So when I think on this study, I think it's an interesting study. It comes from a very high volume center, and they do shed some light on outcomes following these devastating injuries. I think the study can serve to help us define our role in reconstruction for patients. Often they come in with devastating injuries, and it seems like there's no way they could survive an injury like that, let alone get reconstructed. But this data does seem to show that if they are able to survive, get admitted, they do have a very high likelihood of surviving long term. I do wonder if this study is applicable to all centers. Shock Trauma is a world-renowned center for trauma, and they have the infrastructure in place to quickly and efficiently handle these types of injuries. I'm sure that also plays a role in the high survivability that other smaller hospitals might not have. I also wish they would have looked at total cost for the system in this study. And lastly, I think it's important to point out that the study population is quite small, as it is focused only on self-inflicted gunshot wounds to the face that do not affect the neck or the calvarium, which is a very small subset of patients who fit this criteria, and that needs to be kept in mind when reviewing their survival outcomes. I think with that, I'd like to ask Dr. Sachss what his thoughts are on this study and what he thinks we should take away from it.
So I think it was a very nice study at a high-volume center here in Baltimore, Maryland, and what's important about it is that they really just focused on the gunshot wounds to the face of those patients that survived. And I agree with your comment about it not including gunshot wounds to the neck or the calvarium. Typically, specifically with the calvarium, those patients will wind up with debilitating neurological injuries and ultimately probably succumb to the injury. But these are the patients that had a devastating injury to the face that went on to live. And I think when you think about plastic surgery getting involved with these patients that have been resuscitated, do go on to live during after the self-inflicted gunshot wound, then the question is, what's the timing and what's the appropriate cadence of reconstruction? And I think, from my thoughts on being involved in a patient who has a massive gunshot wound to the face with debilitating injury that has survived, the timing is very important. If you allow the soft tissue envelope to heal around the bony injury, then what you'll have is a much harder reconstruction at a later time, because what will happen is fibrosis will initiate, and you'll wind up probably having a more difficult operation later down the line to help reconstruct these patients as you undergo scarring and potentially even infection. So I think, the takeaway point here is at shock trauma, where they see a high volume, although relatively small number of these patients, the immediate reconstruction of these patients with the devastating bony and soft tissue injuries probably and most likely is the correct thing to do based upon the reconstructive algorithm that they can supply, because they have microvascular craniofacial surgeons on staff dealing with these devastating injuries. And to your point about other hospitals maybe not being able to resuscitate or potentially care for these patients in the same way that they would at a high-level acuity trauma center, I do think that the reconstructive surgeon's role here is critical, because if you can get the bony elements back together early, you set the stage for the soft tissue reconstruction in that acute phase. Whereas if you didn't do that, you would have a much more difficult operation with soft tissue fibrosis and scarring and bony malformation.
Thank you, Dr. Sachs. I think that's what I really wanted to talk about next, is kind of how can we as plastic surgeons use this study and this data to advocate for our role in the patient care from the beginning. A lot of centers, especially if they're not as focused on multidisciplinary types of patient care, the plastic surgeon might never ever get involved with this patient. So how can we, if we're going to smaller centers, try to encourage kind of a multidisciplinary approach to this devastating injury?
Right, and I think that to that point, it's important that the triage is done appropriately. So if a patient has this type of injury at another center that doesn't necessarily deal with in a multidisciplinary fashion, this is almost, as soon as the patient is stabilized, a transfer to a tertiary care center with a multidisciplinary craniofacial team with microsurgical expertise, because once the patient's deemed salvageable and they are going to live, which is what this paper says, that, even though it's a small cohort, these patients with the isolated gunshot wounds to the face, and remember, past the external auditory meatus, below the hair temple line, above the neck, these patients are going to live. So, what that means is if they're going to live, they need to be put back together. And the timing of that is important, because if you do wait and they are left to heal secondarily and then deal with complex reconstruction later, they put themselves at risk for infection and a much higher rate of more difficult reconstructive surgery, because I think the time is critical that you have these soft, pliable tissues that you can put back together. Plus, if you think of it from a craniofacial perspective, you need to reconstruct the bony elements first in order to get the appropriate soft tissue reconstruction. And you can see that with some of the early face transplant work that was done, where the bony elements were not as rigorously studied and reconstructed, whereas the later face transplant patients, really the bony elements were identified and conceptualized and then executed at the highest level of craniofacial techniques, and then the soft tissue envelope followed. So I think what this article points out is that the patient is going to live and be resuscitated, they need to be at a tertiary trauma center with multidisciplinary craniofacial microvascular care.
I think that's a great point, especially, this is not a 1 or 2 surgery kind of thing. I think the study says they range 1 to 16 reconstructive surgeries. This is a patient that you're going to have a relationship with for a long haul, and it needs to be at a center that can really provide optimal care. My other question I had for you is, once they are medically cleared, how do you stage the reconstructions? Are you doing lower face, then mid face, do you mandible, then secondary dental implants, immediate dental? What's your algorithm in your head of how you're fixing these massive defects?
I think it comes down to the basics of dealing with the bony injury and then the soft tissue elements. And as I said before, I think that the bony reconstruction has to be dealt with first. You have to make sure that you have devitalized bone removed. You have to make sure that the wound is stabilized, the soft tissue envelope is stabilized. You don't have devitalized tissue. But I think to your question, especially these injuries, especially if they come through the lower portion of the face from the submental region, these are blast injuries which potentially blow out the mandible and the maxilla. So I think the idea would be to do the work from the lower third and then the middle third up, because you need to either reconstruct or stabilize that mandible with ORIF or external fixation, or free fibular reconstruction or bony reconstruction, and then you work to the maxilla. And I think the idea is that once you get the bony stabilization from the lower third, then the middle third, then you work with the soft tissue envelope. It all happens in concert, almost like in symphony. You have the cello is playing and the violin's playing and the drum's going. You'll all have to sort of work in concert for it to go well. If you just focus on one thing at a time, I think you don't get the best outcomes. But I do think that the bony reconstruction takes precedence, the craniofacial reconstruction, stabilizing the bone, the mandible, then the maxilla with plates or bone grafts or non-vascularized bone grafts or vascularized bone grafts, and then the soft tissue envelope will follow suit and not the other way around. When you stabilize the patient initially, you have to get the soft tissue construct back together, but I think the final soft tissue envelope has to follow suit with the final bony reconstruction, mandible, maxilla. Your question about implants, I don't have a ton of experience with immediate dental implants. I think that's the highest level where you have oral surgery and dental expertise on board in your institution where they're putting in dental implants into the free fibula almost before you transfer it, which they do that often for oncological reconstruction. And I think that's the kind of stuff that if you have access to it, you're talking about some very high-level reconstruction right away, returning that patient to activities of daily living that much quicker.
Raj, what are you guys doing at WashU for these kind of patients? What's kind of your algorithm in treatment? What have you seen?
Yeah, it's very similar to what the authors talk about. I think it's true that a lot of the self-inflicted gunshot wounds, at least in my experience, do survive. I think the one big difference between our management and kind of the management that they describe and that Dr. Sachss is talking about is that for us it's very difficult traditionally to get these patients in and do the reconstruction early or immediately, which I think is probably the optimal way to do it. And I think that's because it's different when you have an isolated face injury, an isolated mandible plus mid-face compared to when you have a penetrating brain injury and some of the other issues that they excluded in this study. And I think the other main difference when we're just talking about firearm injuries is that a majority of our firearm injuries are not self-inflicted. They're victims of violence. And in that case, there's often multiple gunshot wounds or multiple concomitant injuries that prevent us from traditionally being the first people to intervene. So oftentimes what we do is when we reconstruct them, what Dr. Sachss mentioned is completely true. And I think that really is the gold standard, is early involvement, because soft tissue envelope starts to scar down. And then really once that happens, it's very, very difficult to get things right. And then you're always kind of chasing yourself and you're doing multiple revisions, free flaps for bone and then a secondary flap for soft tissue reconstruction. And that's traditionally been our management, is that when we do these patients, the self-inflicted ones and also just the firearm injuries in general to the face, is that we're not doing them within the first week often as far as the definitive procedure goes, whether it's bone grafting, vascularized bone grafting, or soft tissue reconstruction. We're usually doing them after the first 5 to 7 days. And then what we find is that we're having to do multiple revisions to get things right, both intraorally and extraorally. So I think this is a great paper in that it kind of guides your management to be earlier. And I think a big part of it is convincing the other services involved, because these patients are all trauma patients, convincing them that this is kind of a critical thing as soon as they're stable to take care of. And I think that's a big kind of, at least in our institution, would be a big shift in the way things are managed.
Just to speak to the paper and then, Raj, what you discussed, what's happening at WashU, you're including all the patients, the trauma patients. What they really focused on in this paper is the isolated gunshot wound to the face. The gunshot wound to the face that they transplanted, that Ed Rodriguez and team at Shock Trauma, that was a self-inflicted gunshot wound. And, the interesting thing that I think this paper sort of begs to ask is, what does it mean to the patient who has attempted suicide and then they're reconstructed in that immediate fashion? How does that help them psychologically down the line? Because think about that. If you unfortunately had that event, but then you woke up and you recovered from this incident in your life and you were actually back in place, my assumption would be that those patients probably do better as time goes on versus somebody who is left to deal with the injury and to look at themselves in the mirror every day. So, this is the kind of thing that behooves plastic surgeons to get involved immediately, because not only functionally, like to eat and drink and get back into activities of daily living, but actually psychologically to move past that injury, because they're not dead, they're alive. Maybe they have a second chance, and they view that better if they see themselves reconstructed.
Lily, have you had issues at Duke getting the other services on board with you guys treating these patients early on, or are you in the same position Raj is, where you're getting them a little bit later after their injury?
We actually are really fortunate to have our director of craniofacial trauma to have done a lot of his training at Shock Trauma, and so we've developed a really nice relationship with our trauma service. There's definitely a subset of patients that come in either unknown if it was self-inflicted or if it was non-self-inflicted gunshot wound to the face that has, some intracranial involvement. And often with those patients, we're waiting at least a couple days before really intervening to sort of allow a determination of what the neurologic status is, what the overall picture is for that patient, what the family status is. But we've had a handful of patients who've had, truly isolated self-inflicted gunshot wounds to the face, very similar to what they're describing here. And I would just sort of echo what Dr. Sachss was talking about and how difficult their management can be. And just getting the opportunity to see, a handful of these patients post-operatively over the course of 1 or 2 or 3 years after their injuries, like they're still dealing with a lot of, revisionary procedures and issues in regards to their facial reconstruction. And so I think a different thought process about all of this is just the involvement of psych, and probably the involvement of psych early and as an outpatient. I think that's something they touched on a little bit in the paper and kind of discussed the percentages of patients who are being discharged to an inpatient psych facility. But I'm assuming that, the rates of pre-injury diagnosed psychiatric or substance abuse disorders is probably under-captured or underdiagnosed in their sample, and that this plays a huge role as an outpatient, since these are really challenging reconstructions. And these patients, I can't imagine many scenarios where they're going to walk away and someone doesn't know by looking at them that they've had some type of injury to their face. So I think that probably just makes it even harder for these patients who are already having a difficult predisposition to some difficulty in navigating their lives.
Yeah, I think that's a great point, Lily, that even though they mentioned the psychiatric illness, I think it is often misdiagnosed or underdiagnosed in this patient population. So I think lastly, I'll talk with Dr. Sachss and see if he has any more pearls to give us on this article.
My concept of this is that multidisciplinary care with expertise in microvascular surgery, craniofacial surgery, is paramount to the successful outcome of the reconstruction of the facial skeleton and the soft tissue envelope. I think that some of the things that, as we move forward with technology and sort of dissemination of virtual surgical planning, I think these things can come into play in these kinds of operations where you have these devastating injuries where you have large mandibular defects or maxillary defects. You can use virtual surgical planning, map out these operations ahead of time, and come up with these templates, cutting guides that will help you cut that mandible, cut the fibula for mandibular reconstruction, cut the fibula for maxillary reconstruction. So these operations, which sometimes took a lot of hand-eye coordination and burrowing down and jiggering the bony construct into the maxilla and the mandible, I think with virtual surgical planning and craniofacial expertise at your institution, you can make this operation go at a higher level. I do think that the earlier you get involved with this as a reconstructive surgeon, the better outcome the patient is. And I do think that, just to mention, this is somebody who comes in at risk, who's tried to take their life for whatever reason. They could be on, substance abuser, they could be stressed from something in their life. But I think that if you help this patient early and you reconstruct them, I really do think that you'll wind up sort of minimizing costs to society and healthcare later down the line. Those are my thoughts about this article, and I think that it really points out an interesting small subset of population that we have, but these cases, you can really cover the full breadth of plastic and reconstructive surgery.
Thanks. Well, I think with that, we will end the discussion of this article. Thank you, everyone, for a great discussion. If you like this podcast, please feel free to share with your colleagues and friends and rate us in the Apple iTunes Store. Remember to tune in to the other 2 articles that we'll be discussing on this month's podcast. Go ahead and like the Plastic and Reconstructive Surgery Facebook page if you have not done so already, and join us later this month for our interactive real-time discussion with this month's selected article authors. And once again, I want to thank Dr. Sachss for joining us.
All right.
Thank you for listening to the award-winning PRS Journal Club podcast. Be sure to read all of the articles being discussed, including some of the classic pairings from the archives, for free on prsjournal.com.